Hello and welcome to Module 2 of 5 total for Clinical Infectious Diseases Assessment and Management, designed for residents, students, or any clinicians who want to prepare for clerkships or residency rotations in infectious diseases. My name is Jackson Stewart. I'm an infectious diseases clinical pharmacy specialist. In this module, we're going to focus on the fundamentals of antibiotic pharmacology. That is, focusing on the details of antibiotics that is need to know for most infectious diseases cases. There's a lot to get into and some memorizing that we're going to be doing today, so let's get straight into it. In this module, we're going to focus on developing a way to be able to recall all antibiotics using mnemonics when thinking of possible antibiotic options. We will clearly outline the spectra of activity for each antibiotic agent using our truncated bacteriology schema we made in Module 1. We will highlight class-specific clinical considerations of antibiotic classes such as important adverse effects and other clinical tips. And lastly, we'll briefly touch on the role of clinical pharmacokinetics in infectious diseases for clinical practitioners. Of course, there is a lot of nuance and whole degrees and formal fellowship programs dedicated specifically to antibiotic pharmacology and clinical pharmacokinetics and dynamics. If you're interested in some esoteric nuance, please come and round with me on our infectious diseases service. For 95+% of clinicians, the absolute fundamentals will do, but more importantly, thinking about antibiotics like an infectious diseases clinician. We will not cover other antimicrobials such as antivirals or advanced clinical PK/PD in this module. When it comes to learning antibiotics, there are many fine details that could be discussed. Further, when thinking about antibiotics clinically, there are many things you could choose to focus on, for example, dose, duration, route, interaction, side effects, etc. However, there are few actions regarding the manipulation and assessment of antibiotics that form over 95% of the impact that will actually benefit the patient. Instead of using the brunt of your valuable time over-analyzing nuanced principles, our efforts should be focused on first, if antibiotics are warranted in the first place, which is the most important action to start or stop antibiotics if not needed. Second, to ask if antibiotics are needed, which is the best antibiotic selection. And third, if needed, how long exactly should therapy be? This, of course, being related to number 1 and stopping antibiotics. Other considerations like dosing are of much less impact comparatively and are easily and quickly looked up, so we should spend the majority of our time here. Similarly to our microbiology, memorizing antibiotics is a difficult task for residents and students. However, in order to be able to create a list of antibiotic agents, we need to find a way to be able to memorize all available antibiotic options in a concise and organized way. After having this schema, we need to memorize the spectra of activity for individual agents and classes in order to be able to apply that knowledge to selecting an antibiotic. In this module, we'll provide an overview of these spectra of activity, but no didactic can replace your local antibiogram data, which reflects the sensitivities of specific bacteria in your locale to individual antibiotic agents. Learn now how to access your local antibiogram to help with bedside decision making. When I think of antimicrobial agents, just like my microbiology, I start at the very beginning with an overview of all of my various classes of agents. Remember that there are not just antibiotics, but antivirals, antifungals, and antiparasitic drugs that can be deployed against infectious diseases. Here, we'll focus on antibiotics. Antibiotics are a bit messier than the microbiology to memorize, so we're going to need to use some heuristics and mnemonics to help us with recalling them all when we need to. Functionally, I split up all of our various antibiotics into 3 large categories, each of which will have its own mnemonic. The first I call gram-positive specialty, although there are dangers we've previously discussed with these oversimplifications. The next group are most commonly used against gram-negative organisms, and then our small third group, which is a specialty group, mostly used for atypical and anaerobic organisms. The first mnemonic I memorize is BLVCR, which stands for beta-lactams, of course, which includes penicillins, cephalosporins, carbapenems, and the monobactam aztreonam. The V stands for the 3-drug cocktail of very similar agents in spectra, vancomycin, linezolid, and daptomycin, and the CR stands for clindamycin and rifamycins. The second and last mnemonic I memorize is FAN-PST with 2 Fs, which stands for phosphomycin, fluoroquinolones, aminoglycosides, nitrofurantoin, polymyxins, and the ST for sulfamethoxazole trimethoprim. The last group includes 3 groups, 2 for atypical organisms, macrolides and tetracyclines, and 1 for anaerobes, being metronidazole. And with that, all of the antibiotic agents you need to know of are packaged as neatly as we can into smaller mnemonics so that we can recall them when needed. These larger groups are less helpful, as we'll see that the spectrum of activity can cross-contaminate between different organism groups. Take time if needed to revisit these mnemonics to make sure that you're reliably able to recall all the antibiotics that we commonly use in infectious diseases. Now that we know our antibiotic classes, we can now place them into our truncated bacteriology schema we made in Module 1 and discuss their spectra of activity and the differences between individual agents. As previously stated, always learning spectra of activity in this fashion will reinforce our basic knowledge of the most common pathogens, but also prevent error from oversimplification in memorizing trends instead of specifics. It is important to remind ourselves that even though we learn that a bacteria is either resistant or susceptible to an antibiotic, in reality it is not that dichotomous. Predicting susceptibility of an antibiotic to a pathogen is more like a probability of treatment success, i.e., how likely is it that giving this drug will lead to actual antibacterial activity. Different parts of the world may have different susceptibilities with regards to the same organism since they mutate locally and change resistance patterns over time. Here we will discuss a good starting point to use when thinking about antibiotics, but for your individual patients it would be prudent and intelligent to review and become familiar with local antibiogram data before prescribing. In my truncated schema table, I use dark red for nil activity, which means we would not predict that the organism would be susceptible to this antibiotic at doses that are tolerable. I use green for my predictable activity, that is, I would suspect that the organism, even empirically, before susceptibility results, should respond to this antibiotic. I use yellow for unpredictable activity, that is, it may very well be that this antibiotic could be effective for this organism, but I might wait until the susceptibility report returns before prescribing. Lastly, I use a blue square for synergy possible. This means that there might be niche uses of this antibiotic for select cases in combination with other agents for clinical treatment. More on that later. Now let's get into some spectra of activity. I'll put a timestamp in the description for this section so you can come back to it if you need to while learning and memorizing. I'll also include a PDF of these schema tables that you can download for reference. However, if you can memorize these, this will work best for you clinically to speed up the assessment process. One of the most important groups of antibiotics is the beta-lactams. Let's start with natural penicillin. Penicillin G if parenteral, or penicillin VK if oral. Always moving left to right through our schema, penicillin does not cover MSSA, MRSA, cons, or Enterococcus, but is an excellent choice for most streptococci. There is some unreliable activity against Enterobacterialis, but it would be rarely used for this reason. Penicillin has good activity for oral anaerobic bacteria, making penicillin a good choice for dental abscesses or infections. However, the dominant use of penicillin is still in the treatment of syphilis, a spirochete which cannot become penicillin resistant. Among the other penicillins, let's highlight some key differences in spectra. The anti-staphylococcal penicillins, like cloxacillin in Canada, have added activity against MSSA, a great choice for this, but not MRSA, in its namesake resistant to these penicillins. However, these penicillins sacrifice their minor coverages, in particular against anaerobes for this reason. The aminopenicillins, like amoxicillin or ampicillin, lose that activity against MSSA, but acquire activity against Enterococcus faecalis, not faecium. Remember, no beta-lactams typically have activity against Enterococcus faecium. Amoxicillin not infrequently can be used for some Enterobacterialis or miscellaneous bacteria, but usually only after susceptibility has been confirmed, for example for E. coli. Aminopenicillins also cover our oral anaerobes sufficiently. Amoxiclav, or ampicillin sulbactam in the States, is the combination of an aminopenicillin with a weak beta-lactamase inhibitor called clavulanate, which adds some broader coverage across the board, but more diarrhea, unfortunately. With amoxiclav, we can usually kill MSSA, Enterobacterialis, miscellaneous bacteria, and more anaerobic bacteria than we could with amoxicillin alone. However, we still can't kill MRSA, Enterococcus faecium, or the more resistant gram-negatives. Lastly, piperacillin tazobactam is the broadest spectrum penicillin BLI combo, adding on top of amoxiclav reliable Pseudomonas coverage. In this way, if you're ever thinking of using piperacillin tazobactam, but realize you don't need the Pseudomonas coverage, amoxicillin clavulinate, which can also be given IV, is a better choice. Now moving to our cephalosporins. Worldwide, there are many cephalosporins, all with similar names, so memorizing them is difficult. We'll focus on the ones we use in Canada and discuss them by generations, which is useful to group them by spectra of activity. You'll notice that no matter the generation, no cephalosporins have activity against any enterococcus. Our first generation cephalexin and cefadroxil, which are PO, and cefazolin, which is IV only, are highly effective against MSSA and are most used for this pathogen. They also cover streptococcus reliably, making this group great for skin and soft tissue infections. They have some unreliable activity against Enterobacterialis like amoxicillin, but don't have the anaerobic activity it has. Our second generations, like cefuroxime and cefoxitin, are not as reliable against MSSA, but retain their streptococcal coverage and have slightly more reliable activity against miscellaneous bacteria and oral anaerobes. Second generation cephalosporins have niche uses, but most are uncommon and you won't see much of them in clinical practice. Third generation cephalosporins, however, are widely used, ceftriaxone, for example, being the most commonly used one, and its cousin cefotaxime, which have unreliable MSSA activity but strong streptococcal activity and Enterobacterialis activity. When Enterobacterialis organisms are suspected clinically, ceftriaxone is usually a common empiric choice, for example, for a urinary tract infection or intra-abdominal infection. Another third-generation cephalosporin is ceftazidime, but it is unique in that it is the main cephalosporin with activity against Pseudomonas. There are additional broad-spectrum and hard-to-acquire cephalosporins that are beyond the scope of this module. Lastly, we have our carbapenems and monobactam. Carbapenems are very broad-spectrum agents that should be restricted, i.e. only used in scenarios where drug-resistant pathogens are justifiably expected. Not only do we often not need to cover many drug-resistant pathogens, but pressure on our microbiota with strong antibiotics like this can promote the development of resistance over time. Carbapenems in general are effective against MSSA, Streptococcus, and Enterococcus faecalis, as well as most gram-negative organisms except for Stenotrophomonas, which is intrinsically resistant. Carbapenems are also effective against oral and colonic anaerobes. One nuance is that ertapenem has less reliable activity against Enterococcus faecalis and Pseudomonas, so if these organisms are suspected, a better carbapenem should be chosen. Aztreonam is an uncommonly used antibiotic that is primarily active against gram-negative pathogens, including Stenotrophomonas. However, we typically reserve it for multi-drug resistant pathogens once we lose access to our less broad and strong options. Moving along with the rest of our BL-VCR mnemonic, we have vancomycin, linezolid, and daptomycin. These three agents vary in their tolerability and side effects, but are almost identical in their spectra of activity, being very strong coverage against all three of our primary gram-positive pathogens. The key nuance is that a small proportion of Enterococcus faecium is known to develop resistance to vancomycin, which is known as vancomycin-resistant enterococci, or VRE. In cases where VRE is suspected or identified, linezolid or daptomycin are preferred agents. Oral vancomycin, but not IV vancomycin, is also the drug of choice for Clostridium difficile infection, or Clostridioides difficile infection, a colonic gram-positive anaerobic disease. Clindamycin is a lincosamide antibiotic closely related to the macrolides, but with a very different spectra of activity. As you can see, although it has some reliable MSSA coverage, depending on your antibiogram, it has unreliable activity for MRSA and cons, as well as does not reliably cover Streptococcus. Clindamycin is sometimes taught to have good anaerobic coverage or above the diaphragm anaerobic coverage, but in our local antibiograms, clindamycin actually performs quite poorly against most anaerobic bacteria. For these reasons, and because it carries a high risk of C. difficile infection, it is rarely clinically useful or justified. Rifamycins like rifampin and rifabutin are only used in very niche circumstances in infectious disease, the first being used as synergistic agents against staphylococcal biofilm-related infections, i.e. with prosthetic material, or for mycobacterial infections where its use is more evidence-based and justified. It also has some activity against Haemophilus and miscellaneous species and used to be used as prophylaxis for contacts of patients with Haemophilus infections. Now let's get through the second mnemonic, FAN-PST. First, we have fosfomycin, which is mostly used as an oral powder sachet for urinary tract infections, but also has an IV form that is mostly used by ID specialists for resistant organisms. Notice that fosfomycin has great activity against Enterobacterialis and even Enterococcus, making it a good option for lower urinary tract infections like cystitis. It has unreliable activity against other organisms, but in complex infections, it might be used in combination by infectious diseases services. Fluoroquinolones are a broad spectrum group of antibiotics commonly used for gram-negative infections. All fluoroquinolones technically have activity against both MSSA and MRSA, although they are uncommonly used for these pathogens. They cover Streptococcus, probably less so with ciprofloxacin, and only ciprofloxacin might have some activity against Enterococci. Where fluoroquinolones are strong are against most Enterobacterialis, miscellaneous bacteria, spice organisms, and Pseudomonas species. Levofloxacin and moxifloxacin have slightly different strengths, being probably more reliable for Stenotrophomonas, but waiting for susceptibility is probably the best strategy for this organism. Moxifloxacin also has some strong activity against anaerobes if the need to cover arises. Lastly, fluoroquinolones also have great activity against our respiratory atypical pathogens. So even though they are not in that last group of antibiotics, remember that the fluoroquinolones can also be used against atypicals as well. Aminoglycosides are a group of IV-only antibiotics which are strong against gram-negative organisms except for Stenotrophomonas, but because of their nephrotoxicity and ototoxicity are generally reserved once other options like beta-lactams are exhausted. Aminoglycosides also might have synergistic activity against gram-positive organisms when given with beta-lactams, although this use is limited and infectious diseases involvement should typically be sought for this purpose. Aminoglycosides do not cover anaerobes. Nitrofurantoin is another PO-only option for cystitis, aka lower UTIs, since it is generally effective against Enterobacterialis and Enterococcus species. However, its uses other than this indication are limited, despite some unreliable activity against various other organisms. Trimethoprim sulfamethoxazole, aka TMP-SMX, is a two-drug combo featuring two active agents with similar mechanisms of action, useful for a variety of gram-positive and gram-negative infections. TMP-SMX has good activity against MSSA and MRSA, but nil activity against Streptococcus and Enterococcus. TMP-SMX is generally reliable for many gram-negatives, including spice organisms and Stenotrophomonas, but does not cover Pseudomonas. TMP-SMX in this way can actually be considered a quite broad-spectrum antibiotic. Our last antibiotic in this group is the P in FAN-PST, jumping back one, the less frequently used polymyxins class, which refers to colistin and bacitracin. Colistin is a nephrotoxic and neurotoxic medication that is generally reserved once all other options are exhausted, typically for multi-drug-resistant Pseudomonas or spice organism infections. Remember that these can save us once we run out of options for resistant gram-negatives. Now we've memorized and reviewed the majority of antibiotics that are commonly used in infectious diseases. The last small group of antibiotics are specialized against atypicals or anaerobic bacteria. Macrolide antibiotics, including the prototypical erythromycin, clarithromycin, and azithromycin, have various unreliable activities against several organisms like MSSA, Streptococcus, and miscellaneous bacteria, but none strong enough to justify solitary treatment. The real use of macrolides is against respiratory atypical organisms like Mycoplasma species or chlamydia. Tetracyclines, which include the prototypical tetracycline and the newer doxycycline and minocycline, are actually excellent agents against MSSA and MRSA as well. They have some other various activity, but are generally unreliable against Streptococcus, so their use is generally isolated to MSSA, MRSA, and atypical infections. Tigecycline, however, is a very broad-spectrum antibiotic restricted that can kill most organisms on our truncated schema, except for Pseudomonas. Remember tigecycline for when we run into very resistant organisms, but the use of tigecycline should be predominantly restricted to the Infectious Diseases Specialist Service. Lastly, we have metronidazole, an antibiotic which has activity only against anaerobic bacteria, but very reliable activity. The metronidazole will cover almost all oral and enteric anaerobic bacteria. That's a lot to remember. Take the time as needed to re-review those spectra, which will help in later modules when we apply this to selecting an antibiotic for an infectious disease. For practice, let's take a moment to test ourselves by naming all the agents that have activity against some high-yield specific organisms. For MRSA, you should consider our vancomycin-daptomycin combo, as well as tigecycline, but none others for intravenous options. For PO options, we have linezolid, clindamycin, trimethoprim sulfamethoxazole, and doxycycline. Notice that I still try to proceed through the BL-VCR to the FAN-PST and then atypicals mnemonics so that I don't miss any in that order. For enterococci, we know that amoxicillin plus minus clavulanate, piperacillin tazobactam, and carbapenems can kill Enterococcus faecalis, whereas vanco, linezolid, and dapto can kill both faecalis and faecium. Ciprofloxacin, tetracyclines, fosfomycin, and nitrofurantoin might have some activity, but we usually weight susceptibility for these. For spice organisms, we have carbapenems, monobactams, tigecycline, and aminoglycosides as reliable agents. Fluoroquinolones and TMPSMX might be great step-down options once we have susceptibilities. Pseudomonas, we've memorized some options from Module 1, being piperacillin tazobactam, ceftazidime as the only cephalosporin, carbapenems less so with ertapenem and aztreonam. Aminoglycosides are reliable, but fluoroquinolones like ciprofloxacin are not always reliable. Colistin is another agent with good Pseudomonas activity that we reserve for drug resistance. Lastly, for anaerobes, we have oral anaerobic coverage with natural penicillin and amoxicillin, but good broad oral and enteric coverage with amoxiclav, piperacillin tazobactam, carbapenems, metronidazole, and tigecycline. Being able to generate these lists takes practice. The more practice you have, the better you will be at generating antibiotic options, especially once you have more than one pathogen at play. Antibiotic synergy is a topic that is a bit esoteric and is mainly relevant for infectious diseases specialists. Suffice to say, it is a strategy where multiple antibiotics are given at the same time, even though some may not have intrinsic activity against the organism. This interaction may lead to better in vitro killing than either given alone. Although this sounds like a great idea, it is a tactic that has in vitro merit without much in vivo confirmation of patient benefit. In fact, there are very conflicting publications regarding the utility of synergism for many infections. If considering treating using these strategies, infectious diseases specialists should be consulted for advice, given the risks that come from the administration of these agents, which can be substantial. For example, the extensive drug-drug interactions with rifampin or the toxicities of aminoglycosides. Although the different classes of antibiotics have their unique drawbacks with respect to adverse effects, some antibiotics are generally better tolerated than others. Although there is a subjective component to this assessment, it is useful to understand which antibiotics commonly lead to more problems than others, and which in particular can lead to high risk or even lethal problems during therapy. Overall, most antibiotics are well tolerated within their duration, especially if less than or equal to 7 days of treatment, so most of the problems listed in their monographs are likely not to be encountered. Further, many antibiotics can lead to some form of GI disturbance, presumably because of interference with the bacteria in our gastrointestinal microbiota. In general, our beta-lactam antibiotics and our P-only cystitis agents are our best tolerated antibiotics we have. Preserving them as options at all times is in our best interest. Next, tetracyclines, TMPSMX, amoxicillin clavulanate, metronidazole, and macrolides are usually well tolerated but have some specific quirks that are not uncommonly encountered. Clindamycin has a high risk of Clostridioides difficile infection, which makes it more high risk to use than many other agents. Fluoroquinolones, as we'll discuss, have some effects that are thought to be severe but are extremely rare and have consequences of long-term use. Daptomycin can cause rhabdomyolysis during therapy, and vancomycin commonly leads to nephrotoxicity, although it is almost always reversible. Rifampin is very problematic due to the severity of the drug-drug interactions it causes. The antibiotics to pay close attention to are the aminoglycosides, which can cause an irreversible ototoxicity during therapy, especially with longer durations. Colistin is nephrotoxic but also neurotoxic, which can lead to seizure and other severe problems during therapy. Linezolid is typically well tolerated in durations less than 2 to 4 weeks, but longer can cause mitochondrial toxicity and fatality from lactic acidosis, although this is rare. Keeping these rankings in mind can help us when we are trying to pick between 2 or more antibiotic options. The QT interval is a common consideration as a drug-related problem for many medications. In brief, the QT interval refers to the total duration of the action potential from the Q wave to the T wave. Prolongation of this ECG interval has been identified as a risk factor for a life-threatening form of polymorphic ventricular tachycardia called torsades, or TDP. Various agents extend this interval through ion channel manipulation. For antibiotics, this is mainly fluoroquinolones and macrolide antibiotics. However, just because these agents will prolong the QT does not mean the patient will go into TDP. As the prescribing or assessing clinician, if you are considering this as a problem, you should be assessing for all of the risk factors for TDP, which have been identified as hypokalemia, hypomagnesemia, or hypocalcemia, pre-existing heart scar tissue, for example, past MI, female sex, and multiple QT prolonging agents in particular, with a presence of drug-drug interactions which may be exacerbating these QT prolongations. If your patient has less than 2 or 3 of these risk factors, it is probably okay to give these agents, especially for short courses despite a prolonged QT. If there are multiple risk factors present, however, there should be concern, especially once the QTC, corrected QT interval via the heart rate, is longer than 500 to 550 milliseconds. Various clinicians have their own approach to this, but as the assessing clinician, you need to decide if there is enough justification to be concerned about this problem if you are going to be changing or manipulating your therapy based on it. Remember to check for yourself the ECG and QTC, since the computer is very frequently inaccurate about the QTC interval. Small squares are 0.04 seconds and the QTC is equal to the QT interval divided by the square root of the RR interval. An excellent review of this clinical problem was done by Tisdale et al. In 2016. I've shown the reference in the bottom right there. The last nuanced problem I'll discuss before getting into some antibiotic-specific adverse effects is antibiotic allergy. Although beyond the scope of this module, it is important to remember that many patients have antibiotic allergy labels on their charts which do not reflect true drug allergies. This incongruence is known to be due to multiple factors, including inappropriate labeling of side effects as an allergy, misdiagnosing a rash or reaction as drug-related when it is not, mislabeling a benign type hypersensitivity as anaphylaxis or IgE mediated when it is not, and the fact that we know that IgE mediated reactions wane in sensitivity over time, i.e. reactions that were real 20 years ago, are no longer present due to natural loss of sensitivity over time. Clinically, whenever you run into a patient with antibiotic allergies, you should always clarify the label with 1. What specific agent with the name which was involved, 2. The specific reaction, so all details relevant, 3. The timing of the reaction, for example, after how many doses did the reaction occur, and 4. How long ago did the reaction occur, to best equip the team to plan and manage how to navigate antibiotic therapy. Locally, you may have ID expertise that is able to assist in managing and circumnavigating antibiotic allergies. Ask them for help. Now we'll take a look at specific antibiotic classes and highlight need-to-know adverse effects and practical tips. Beta-lactams are very well tolerated in most patients. Third-generation cephalosporins and amoxicillin clavulanate might have a higher risk than some other agents for Clostridioides difficile infection, but this might be due to frequency of use. There are very few drug-drug interactions with beta-lactams, but an important one to know involves carbapenem antibiotics. Specifically, carbapenems are known to decrease valproic acid and anticonvulsant levels by reducing enterohepatic recirculation, which can lead to actual seizure activity. We try to avoid carbapenem use in these patients on VPA, but if this cannot be avoided, our neurology clinical colleagues should be asked for advice and monitoring should occur. Some practical tips are that cloxacillin is well known to cause thrombophlebitis and burning on peripheral IV administration, so sulfasalin is typically preferred for MSSA unless a central line is available. Regarding allergy, penicillin antibiotics all share a very similar ring structure, so are all considered cross-reactive for IgE-mediated allergies. However, cephalosporin allergy is probably mediated by their R1 group, which is circled to the left for ceftriaxone there, so cross-reactivity is structure-dependent. There are many cross-reactivity tables available which should be consulted for use when cephalosporins are implicated with IgE-mediated allergy. For the V portion of the mnemonic, we have vancomycin, linezolid, and daptomycin, all used for drug-resistant gram-positive infections. Vancomycin is known to cause a reversible acute tubular necrosis with therapy related to duration, usually greater than 3 days of treatment. We can minimize this toxicity by providing hydration, but also possibly, if doing therapeutic drug monitoring, by keeping vancomycin troughs below 15 milligrams per liter. Vancomycin, when given with piperacillin and tazobactam, might also increase serum creatinine more than when given alone. This might be due to artificial creatinine increases and tubular secretion inhibition, but it is not known fully at this time. Practically, therapeutic drug monitoring is a common strategy used with vancomycin, but very uncommonly positively impacts patient care. TDM is not routinely recommended unless treatment is expected to justifiably continue longer than 7 days. Linezolid, as we said previously, has been associated with some severe effects that are predominantly associated with long durations of therapy, i.e. greater than 14 to 21 days. In particular, patients may experience neurotoxicity or paresthesias, or blood dyscrasias, most commonly thrombocytopenia, that might be mitigated with vitamin B6 use. Serotonin syndrome can occur with the use of concomitant serotonergic agents, since linezolid is a weak monoamine oxidase B inhibitor. Lastly, with very long courses, linezolid might negatively affect human mitochondrial function, which can lead to lactic acidosis due to interruption of oxidative phosphorylation, which has been fatal in some cases. Practically, however, short courses are generally well tolerated. An important note about linezolid, it is nearly 100% bioavailable, so should always be given orally if a patient is able to take oral medications. Consider practically given intravenously. Daptomycin is a unique agent that has some minimal toxicities other than uncommon rhabdomyolysis associated with treatment. This risk probably doesn't increase when given concomitantly with statins. In particular, we usually check a baseline creatine kinase or CK to monitor this, in particular with long durations, and monitor clinically for muscle pains. Daptomycin and linezolid are restricted agents in some hospitals and require ID consult or antimicrobial stewardship review when prescribed. Clindamycin, as previously stated, is the antibiotic with the highest known risk of Clostridioides difficile infection, an opportunistic infection causing severe diarrhea. For this reason, also due to limited spectra of activity, it should be avoided unless needed. One of the niche uses of clindamycin is for its possible and theorized antitoxin effect against exotoxin-producing Streptococcus pyogenes or group A strep when involved in necrotizing fasciitis. Rifampin and rifabutin commonly cause nausea that can be dose-limiting, require splitting up a high dosage over more frequent administrations. Notably, rifampin can cause some bodily secretions to be tinted orange, although this is never a reason for discontinuation. More importantly, rifampin is a very strong cytochrome P450 enzyme inducer, which means that it will increase the activity of many cytochrome P450 enzymes, including 3A4, decreasing the efficacy of several other important treatments, for example, oral anticoagulation. This is a severe interaction, and thus careful consideration is required prior to prescription. Phosphomycin is a very well tolerated antibiotic and is usually given in a single oral dose of 3 grams as a sachet powder. IV phosphomycin, which does not have many known documented adverse effects, is reserved for infections against resistant organisms. Fluoroquinolones are commonly taught as having very severe and black box adverse effects. Most commonly, fluoroquinolones are very well tolerated, other than a risk of diarrhea and Clostridioides difficile infection that many antibiotics have. In some large publications observing thousands of patients who have taken fluoroquinolones, use of these agents was associated with a small increase in connective tissue problems ranging from tendon rupture, predominantly Achilles tendon rupture, but also aortic aneurysm. Although this association is not very strong, it gives us another reason to limit the exposure that our patients have to antibiotics as much as possible. That said, if a patient had a real infection where fluoroquinolones were the best choice among our available options, I would not withhold fluoroquinolones for this reason. Practically, fluoroquinolones have great PO bioavailability and, again, can be given PO whenever possible. Aminoglycosides are IV-only antibiotics with 2 primary toxicities. First, a reversible acute tubular necrosis, which rarely requires dialysis, and second, an irreversible ototoxicity from cranial nerve 8 damage that causes hearing loss and vestibular illness, which can unfortunately be permanent to some degree. When aminoglycosides are thought to be needed for longer than 14 days, audiometry assessment is recommended to get a baseline, and so this can be monitored. This ototoxicity might be increased with concomitant medications like loop diuretics as well. However, again, if aminoglycosides are the best treatment, a risk-benefit discussion should be had despite these adverse effects. Nitrofurantoin is another well-tolerated antibiotic when used for common durations for cystitis, uncommonly when recurrently used or used for very long-term prophylaxis, which is rarely indicated. Nitrofurantoin might be associated with drug-induced interstitial lung disease. Other than that, nitrofurantoin has nil important drug interactions but is really only useful for cystitis since there are minimal studies supporting its use for other infections, even for pyelonephritis. Trimethoprim sulfamethoxazole has several key adverse effects that every clinician needs to know about. Importantly, the trimethoprim component, the most important component, is known to interfere with tubular secretion of both serum creatinine and serum potassium. This is done through MATE2K inhibition, a transporter on the proximal convoluted tubule. This causes an asymptomatic and artificial serum creatinine increase that is not reflective of kidney injury, but simply this drug interaction. Although this is not clinically harmful, many clinicians are unaware and may react to this or avoid TMP-SMX for this reason. However, this interaction can complicate assessment of renal recovery or function, and so avoidance for this purpose could be justified. The more important interaction is the serum potassium increase, which is not necessarily harmless, and when co-occurring with other potassium-increasing drugs, for example spironolactone or ACE inhibitors, can lead to a clinically relevant hyperkalemia that should be monitored. Rarely, TMP-SMX causes a photosensitivity reaction and other immunologic-mediated rashes. Some clinical pearls for TMP-SMX is that it is commonly used for non-bacterial infections like PJP pneumonia, which is a fungus, and toxoplasmosis, which is a parasite. Dosing is usually done via the trimethoprim component. For example, 5 milligrams per kilo per day is dosed for the trimethoprim component. Lastly in this group are the polymyxins, which are, as previously stated, neurotoxic, involving paresthesias, seizures might be possible, and nephrotoxic with a high rate of acute tubular necrosis. Colistin dosing is also complex and confusing since it sometimes is expressed in milligrams of its salt or cholistemethate sodium or its base just as colistin. Typically, infectious diseases or a cystic fibrosis team should be consulted for use in monitoring. Lastly, macrolides are generally well tolerated but form problems mainly through drug-drug interactions. Where rifampin was a cytochrome inducer, macrolides are strong cytochrome P450 inhibitors, where they decrease metabolism of many other drugs, increasing the risk of toxicity experienced. These are very common and depending on the combination, for example, clarithromycin and colchicine, can be noticeable and clinically significant. Azithromycin notably has a long half-life, which allows it to be dosed once daily and with a shorter total frequency than other agents. Macrolides also have great PO bioavailability, so should always be used PO whenever possible. Tetracyclines have a historical bad reputation for several adverse effects, for example, tooth staining, poor absorption with calcium, and photosensitivity reactions that in retrospect were mostly associated with the prototypical agent tetracycline. Doxycycline and minocycline, newer agents with different chemical structures, are less frequently associated with many of those effects. Specifically, doxycycline is known to be effective even when taken with calcium-containing foods and products. Tooth staining in pediatrics is not only reversible, since many of these teeth are deciduous, but it is actually manageable via dentistry. Nevertheless, this reaction has actually not been clearly observed with doxycycline. In the event that a pediatric patient needed doxycycline, these historical poorly correlated effects should not cause you to withhold prescribing doxycycline. Notably, tetracyclines are great against atypical infections, but as we know, are also great anti-MRSA agents. Lastly, metronidazole is a well-tolerated antibiotic that bothers patients primarily via dysgeusia or poor taste or metallic taste, as well as rare peripheral neuropathies that are reversible that occur with longer treatment durations. Rarely and possibly controversially, metronidazole has been associated with a disulfiram or antabuse-like reaction with alcohol. This does not happen in every patient and is probably genetically mediated. Metronidazole is another drug with excellent PO bioavailability and should be given PO whenever possible. In this next section, we will briefly discuss the role of clinical pharmacokinetics, a complicated science that attempts to correlate in vitro and animal data to expected clinical outcome. Suffice to say, in clinical infectious diseases, we are using our knowledge of antimicrobials to make real bedside decisions to best help our patients. In many ways, theoretical and preclinical data can be interesting, but ultimately to make the best decisions, we need high-quality data or a patient-centered clinical approach to prescribing. The graphic on the left is one that I love regarding perspectives on how to diagnose a urinary tract infection. The graphic on the right I think ties well to the role of clinical PK in actual medicine. Although concepts like penetration into the site of infection and theorized special dosing for certain antibiotics is based on some biologically plausible in vitro and simulated data, to make a decision, I prefer to trust clinical outcome data or clinical observation of my patients. For those who don't know, PK/PD studies involve the collection of data using animals, healthy volunteers, or simulated patients where doses are provided and serum concentrations are tracked. The proper role of clinical pharmacokinetics is to provide hypothesis-generating data for the creation of clinical outcome-based studies asking the question, does this theoretical dosing principle actually affect how real sick patients do? Based on subsequent clinical outcome studies, negative results should be discarded as theoretical non-proven concepts, and positive results should be gathered and scrutinized for consideration for bedside application. Unfortunately, this is not what is routinely done historically despite the rising popularity of evidence-based. Instead, in practice, we see remnants of the traditional PK/PD historical paradigm still in practice, where in vitro or simulation studies will directly inform bedside practice. For example, using higher doses of ciprofloxacin or piptazo for Pseudomonas infections. This is in stark contrast to the new EBM paradigm, which has these types of studies at the bottom of the evidence pyramid, feeding higher levels with hypothesis-generating data. Although the latter approach is gaining favor, many principles that were developed and implemented in the 1960s and 70s persist today and have permeated medical education for decades. Unlearning these principles takes time, but more importantly, focusing on doing what is best and most impactful for the patient should always be the guiding light. For some perspective, I get the following question almost on a daily basis, something like, does drug X penetrate into organ Y enough? When I hear a question like that, I know that the actual question is drug X effective for disease Y, but requires clinical outcome data to support definitively. I wonder, however, does the clinician asking me really care about penetration? Have clinicians been conditioned to accept data like organ penetration as an acceptable surrogate for clinical outcome data? Certainly, there are examples to contradict a theoretical principle like this. Ultimately, acting on information of this quality can lead to non-evidence-based decisions. Let's briefly discuss an example to demonstrate how actually applying clinical PK instead of evidence-based medicine at the bedside is simply more complicated than we should be attempting. An 86-year-old male, for example, type 2 diabetes, peripheral vascular disease, chronic liver disease, admitted with sepsis related to COVID-19, and secondary bacterial pneumonia with Staph aureus necrotizing pneumonia, requires VV ECMO. The patient is severely fluid overloaded, has acute on chronic kidney disease requiring CRRT. During this patient's stay, the patient develops a line-related Enterobacter cloacae bacteremia and is prescribed meropenem. So a question I might get asked actually in real life is, hey, what is the right dose of meropenem in this guy? So let's just look at a few PK insults that I could track that could affect this patient's serum concentrations of meropenem. So, for example, the type 2 diabetes and peripheral vascular disease are decreasing peripheral circulation, perhaps reducing drug delivery. The patient has liver failure, which might increase drug levels because of reduced phase 1 and 2 metabolism, reduced clearance via the biliary route, and an increased volume of distribution due to third spacing. The necrotizing lung infection itself might reduce drug delivery and might cause local edema and an increased volume of distribution, so on and so forth. You get the point. Ultimately, no clinician can or should attempt to track these PK insults to make actual bedside decisions. Not only is any attempt to do so a complete guess, even if it's a well-educated guess, but it is certainly inaccurate. Basing bedside decisions on information like this is more likely to lead to unnecessary time wasted and dose manipulation, where time might have been spent on assessing whether or not the meropenem was actually indicated in this case. So then you might ask, well, what are we supposed to do with all of this clinical PK data that we have access to? First, ethically, I think that primum non nocere applies. We should do no harm. Sometimes that means that when we are faced with a clinical problem, we might do nothing if we think that it could reasonably lead to more harm than good. Given the very poor quality data supporting some clinical PK principles, the amount of good done can very realistically be hypothesized to be zero. This should be incorporated into a risk-benefit analysis that we weigh for all clinical decisions. Clinically, this looks like if you are thinking of increasing a dose and introducing a higher risk of toxicity based on a theoretical principle, even small amounts of risk might outweigh the possibly negligible benefit. The reverse, where there may be a possible benefit to reducing the dose or duration, where safety may be increased for the patient, could be actionable if carefully considered in the absence of any clinical outcome data. Always, we should be honest about our risk-benefit analysis. In Module 2, we extensively covered details regarding the spectra of activity for all of our antibiotics, memorized our antibiotics using some mnemonics, explored each class specifically for adverse effects and pearls that are relevant in real-life practice, and discussed some of the problems with clinically applying theoretical PK/PD data. I encourage you to re-review these antibiotics and become more confident in your memorization of spectra of activity, as well as the most common adverse effects to monitor for each class. Once again, I've included a PDF of the spectra of activity schema, some bonus slides on antifungals, as well as a self-assessment quiz for your learning in the description. References are included as well for support of the content and additional reading if interested. Thank you for watching.